Good evening, everyone. We have a 23-year-old male who presented with acute anterior wall MI, for which he underwent successful primary PCI. And now he is keen to know why he had young CAD despite having no traditional risk factors. So our patient is basically asking that whether this MI could have been prevented or not. So this bring in the question of risk assessment. As our patient is very young and he is not having any traditional risk factors, we will primarily focus on the non-traditional risk factors. So non-traditional coronary risk factors. Myself, Dr. Pratik Raval, I am Associate Professor of Cardiology at UN Mehta Institute. So we all know that cardiovascular disease are the leading cause of death worldwide. The atherosclerosis plaquing begins very early in the childhood, and hence the key to prevent coronary events is to identify the individuals who are at risk. By the time patient present with an MI, it's already very late. There are a number of risk assessment tools that are available. Importantly, Framingham risk score, ProCam risk score, WHO risk score system that is provided by the European Society of Cardiovascular Disease, Q risk score. Another ones are Renault, ACC-EHA, full cohort equation, and Joint British Society 3 risk calculators. There are several limitations of these risk assessment tool. One of the major limitation is that what to do with the intermediate group. That means the patient who are having intermediate risk, whether to start treatment in these group or not. We know that high risk patient usually require treatment in the form of statin and aggressive risk factor controls like diabetes, hypertension, and low risk people generally do not require any intervention. But what to do with these intermediate risk group is not very clear with these assessment tools. And many of the patients do not have any traditional risk factors at all, and these tools do not incorporate other non-traditional risk factors very well. Another important limitation is that their validity in different ethnic groups and in certain patient population. For example, there can be a substantial underestimation of risk, particularly in individuals with chronic inflammatory diseases, HIV infection, socioeconomically disadvantaged people, patients with familial hypercholesterolemia, and those who are South Asians. These patient population are not very well represented in various clinical trials of primary intervention. And similarly, in some patient, this scoring can overestimate the risk, like those with higher economic social class, particularly classic European and American patient, those who have continuous access to the preventive services. Another limitation is that they are suboptimally calibrated for modern population. The studies from which these tools have been derived are conducted on older individuals, right? And the contemporary patient population, we all know that the world has, the lifestyle has changed significantly in the last 2 decades. So the applicability of this score in contemporary population is not very well. And that is why we need new risk markers, particularly to reclassify those individuals who fall in the intermediate risk category by these conventional risk assessment tools. There are many non-traditional risk factors like biomarkers in blood and urine, and notably HSCRP, lipoprotein A, homocysteine, etc., and various imaging tools like coronary calcium scoring, ankle brachial index, carotid intima media thickness, and many psychosocial, environmental, and social determinants. We will discuss briefly important ones. So HSCRP is probably the most studied novel risk marker. It's no longer novel, but it's still very important. It's an acute phase reactant, and it increases with all kind of injury, infection, and inflammation. One of the important feature is that the CRP levels are very stable in the circulation. It is not affected by the variation in meals and variation. There is no variation in circadian according to circadian rhythms. So the standard CRP assess determines only when the CRP is elevated manifold, like there is highly elevated CRP level, only then this assess will detect the CRP, like those with infection and inflammation. But the HSCRP assays are particularly designed to detect the CRP level which are within normal or near normal range. Initially, CRP was known to be a risk marker rather than a risk factor, but there are certain data which indicate that CRP may be an actual mediator of atherogenesis by causing endothelial dysfunction via decreasing nitric oxide synthesis and increase in LDL deposition by CRP mediated stimulation of macrophages. And there are many data which shows that CRP does predict the first cardiac events. One of the study that was conducted in that was published in 1997 in NEGM clearly shows that there is linear correlation between relative risk of MI over a period of 8 to 10 years as the CRP level increases. And similarly, there are many other studies that have shown similar findings, that the relative risk of first cardiac events or first cardiovascular event increases as the level of CRP increases. And even among defined risk categories like Framingham, low, intermediate, and high risk, increase in the level of CRP gives additional information about the elevated risk. As the CRP level increases, the risk of first coronary events increases even in the same category. So is there any clinical evidence that inflammation can be reduced by preventive therapies like statin and other therapies? This is one of the study that shows that the CRP level increases in a linear fashion as the BMI increases. So this implies that a simple weight reduction can reduce your CRP level and provide substantial protection. Another study shows that the statin therapy uh, reduces the CRP level. This is one of the study which was conducted in patients with low baseline LDL level but with elevated or normal HSCRP level. And between these two groups, it was seen that the statin were effective to reduce the risk in patients who had elevated CRP level at baseline. Jupiter was the landmark trial of rosuvastatin, which was conducted on apparently healthy people who had elevated CRP levels. And these trials clearly showed a significant reduction in the primary endpoint that was composed of death, MI, revascularization, and stroke. There was 44% reduction of the primary endpoint in those with elevated CRP level. Similarly, secondary endpoint, that was all-cause mortality, was also significantly reduced in patients with elevated CRP level. So despite these evidence, the more recent data, latest one of the recent study that was published in JAMA, they assess various non-traditional risk factors. They assess whether these non-traditional risk factor, whether they improve the risk classification in patients who already have traditional risk factors. But these studies were not very convincing. So that is why these traditional risk, non-conventional risk factors are not recommended in the current ESC guideline. It clearly recommends against using any kind of circulating or urinary biomarkers or even imaging tests apart from CAC, coronary calcium scoring, and carotid ultrasound. Other tests are not recommended. Homocysteine is another risk marker. It is an intermediary amino acid which is produced during conversion of methionine to the cysteine. This is the chemistry of folate metabolism. Will not go into the detail. One of the important causes, important cause of hyperhomocysteinemia is MTHFR deficiency. That is methyl tetrahydrofolate reductase deficiency. And homocysteine is very commonly elevated in general population, and in those with vascular disease, it can be found elevated in as many as 20 to 40% of patients. And folic acid deficiency seems to be the most common cause of hyperhomocysteinemia. The elevated homocysteine level They cause oxidative injury to the vascular endothelium and impairs endothelium dependent vascular relaxation. However, there are many studies which have shown no benefit in reducing homocysteine levels by folate supplements and other vitamin supplements. So, although it seems to increase the risk, correction of homocysteine level doesn't offer any protection. Another biomarker is lipoprotein A, which is probably very well studied, just like HSCRP. LDL is a LPA is a LDL like particle, and it has got a structural homology with plasminogen, and that is how it's also an acute phase reactant. And because of its homology to plasminogen, it inhibits it inhibits endogenous fibrinolysis. It also inactivates tissue factor pathway inhibitor, and it also localizes within atherosclerotic lesion. That is how it promotes atherosclerosis. Um, However, there are studies which have shown minimal or no incremental predictive effects over the conventional risk factor, and hence LPA is also not recommended in the current ESC guideline. Although LPA has shown to be a very good risk marker, particularly for Indians. In Indians, the levels of LPA is particularly high as compared to other population, and in our population, assessment of LPA may be helpful. So coming to the imaging, coronary calcium scoring is again uh, a method to assess subclinical atherosclerosis by quantifying coronary calcium. It is not recommended in the man below 40 years and women below 50 years of age. So important feature of this is that there is a linear relationship with elevated coronary calcium and annual mortality of cardiac origin or MI. That is roughly 2.8% annually. That means it is 28% over a 10-year period, which imparts very high risk to the individual who have elevated coronary calcium. And as we can see, the risk of coronary events increases in a linear fashion as the coronary calcium increases. One of the main utility of these study is to guide treatment decision in those patients who are having intermediate or borderline risk. Means it acts as a risk reclassifier. It can upgrade or downgrade the risk in those who have intermediate risk. If the coronary calcium is say more than 100, then we can consider initiating statin. And in those patients who have zero coronary calcium score, those individuals are not are particularly at low risk for coronary events. So in them we can uh, avoid initiating statin therapy. Another imaging modality is ankle brachial index, very inexpensive clinical tool. A value of less than 0.9 or more than 1.3 is shown to have adverse prognosis on cardiovascular health. Another one is carotid intima media thickness. It is particularly helpful when we want to avoid radiation and when the feasibility is not there, coronary city coronary is not easily available. In that case, we can use carotid intima media thickness. A plaque is defined as a presence of focal wall thickness that is 50%, more than 50% of stenosis, or as a focal region with an intima IMT thickness that is more than 1.5 mm is considered a plaque. And there are many studies that have shown that in intermediate risk patient, the inclusion of carotid intima media thickness can lead to reclassification of those individual. And currently it has been given a class 2B recommendation where CSE is not easily available. Psychosocial factors which are particularly neglected tools. There are many studies which have shown that the risk of cardiovascular events increases in a linear fashion as the stress level increases, and they provide additional information independent of conventional coronary risk factors. And the psychosocial stress include not only the psychiatric illnesses like depression, but also the day-to-day stressors like loneliness and critical life events like death of any keen person. And the current guideline has given a class 2A recommendation even above the coronary calcium scoring to assess the stress markers in an individual. And in those who already have established ASCVD, they should be considered for referral to a psychotherapeutic stress management. So this is very important and not very often utilized tool. Another important marker is ethnicity. We Indians by birth are at high risk of CVD events, and the European guidelines clearly recommends multiplication by 1.3 for Indians and Bangladeshis and 1.7 for Pakistani. That means when we are using the conventional tools and we calculate our risk by that tools, then we have to multiply that risk score with 1.3. That will slightly increase our risk just by being Indian. Another very important but often neglected risk marker is socio-economic determinants. Low income and CVD mortality has been linearly associated, and that has been found in various studies. Low economic status is particularly very important feature for our setup. Work-related stress is also another important factor, and it is determined by job strain, that is high demand and low control at work, often effort reward imbalance. Means in our country, uh, day by day, the competition level has increased in virtually all the field. The best example is probably our own medical field, where work stress is very high, and this is also an independent risk apart from the conventional risk factors. Very important, environmental exposure, environmental air pollution, soil pollution, as well as noise pollution. The air pollution includes not only the particulate matter, but also the gaseous pollutants like nitrogen oxide, ozone, carbon monoxide. And in our country, the indoor air pollution is also particularly important, but still in rural areas, people use fossil fuels like chulas and everything. So the indoor air pollution is also very significant. Similarly, soil and water pollution is also important risk factor because exposure to lead, arsenic, cadmium has been associated with various uh, cardiovascular diseases like hypertension, CAD, stroke. Of particular importance is PM 2.5 particles. That is the particles who have got size of less than 2.5 microns. Those particles do not easily do not easily settle down on the ground, and they remain suspended in the air. We have commonly seen this during the winter months, particularly in the northern part of our country. And there is evidence that reduction of PM 2.5 is associated with improvement in inflammation, thrombosis, oxidative stress, and decrease of ischemic events. And the body of evidence is growing day by day, which is clearly linking air pollution and cardiovascular mortality. And that is why the current guidelines by European Association have recommended that those patients who are at very high risk of CVD should be encouraged to avoid long-term exposure to the area with very high air pollution. And in regions where people have long-term exposure to high levels of air pollution, risk screening program should be considered on a regular basis. It also recommends policy intervention at the population level, like taking measures to reduce PM particles and reduction of utilization of fossil fuels like coal and promotion of electric vehicles and everything. Fortunately, our government has also taken steps in this direction. This is the risk assessment tool by ACC, latest 2019 ACC-AHA pathway, where ACC-AHA recommends risk assessment right from the age of 20 years. Of particular importance is these borderline and intermediate risk group, where we are not certain whether to start therapy or not. In low risk, there is no need to do anything. In high risk patient, we usually give statin, but in this risk, we do not know what to do. So these novel risk factors should be utilized in these category of patients, where these are the various newer risk factors, or we can, or they nowadays call them risk enhancer, like family history of premature CVD, persistently elevated LDL level, chronic kidney disease, metabolic syndrome, and many others, HSCRP, LPA level. So in this category, this can be used. The European guidelines recommend routine screening for ASCVD beyond the age of 40, while ACCHA recommended beyond the age of 20. And this is one of the risk assessment algorithm that has been suggested particularly for Indian patient. In this tool, they have included the LPA measurements in the primary assessment. If the LPA level are elevated more than 50, then the individual is considered a very high risk straightforward, and we can go ahead with statin therapy. And those who are not meeting these criteria, in those further risk assessment with use of with sub measures of subclinical atherosclerosis, like coronary calcium scoring and carotid intima media thickness, can be used. So young CAD is very common in India. Nowadays, we are seeing patients in their third and fourth decade. We no longer consider the patient who are presenting in their fifth decade young anymore. That is how the worst. That is how worst situation is. And these young patients, very often they do not have any traditional risk factors, and here is where the utilization of non-traditional risk factor comes into play, because these risk factors are not very well assessed. There are many people who undergo regular health checkups, where we conduct many unnecessary tests which are not required and doesn't give any additional information as to the ASCVD risk, like psychosocial factors, stress, work-related stress, economic condition, environmental pollution. These factors are not assessed in routine health checkups. So we need to incorporate those factors during routine evaluation. There is also a general lack of awareness of healthy lifestyle. The recent guidelines have focused very much on the diet and physical activity level, but because of time constraint, we have not discussed those in detail. But those are very important part of prevention. Another important issue is public health promotion by the state, and clearly the government needs to do more over and above just showing the statutory warnings in cinema halls. And the most important thing is that we need to develop our own risk assessment tool that is very well tailored to the Indian population, which takes into consideration the emerging risk factors, particularly stress and environmental pollution. So thank you very much.